Good afternoon. Welcome to we think it's the 5th annual edition of PCCM Focus Clinical Updates, but we're going to have to check. We have 3 speakers today. I will give you, first a reminder, CME is on the board, so do that between now and 4 o'clock. We have a slide about conflicts of interest, which one of our speakers will show, and I have none. It's on the next slide. My glasses on. There we go. There we go. So I will briefly introduce our 3 speakers, and then we will start. We're actually going to go in the reverse order of how they're listed on the slide. First is Dr. Brian Clark, the Director of Pulmonary Function Lab. He oversees all the quality control, works on the schedule, all the other really important things, is an expert in pulmonary function testing, and relevant to this talk has been leading the level 1 CPET for many years. He can tell you how many. Has really developed that into an essential diagnostic modality for patients undergoing particularly surgical interventions, and he will tell you more about something he's added on to that selection, which is new and collaborative. Second is Dr. Shoko Haneden, who's the director of the medical ICU. She's had longstanding interest in metabolics, insulin control, and steroids and related things in the ICU. Has had some clinical trials related to tube feeding, enteral feeding, and she will give us some updates on sort of corticosteroids and sort of the metabolic setting. And last is Dr. Daniel Zerkis, who's the medical director of the Interstitial Lung Disease Program. She is going to talk to us about update on antifibrotics, and she may not say this, but I think the 3 antifibrotics that she's going to discuss, if not more, have all been approved as part of clinical studies done here at Yale. So we should be very proud of them. So thank you very much, and we will start with Dr. Clark. Are you next, or you need to? Okay, that's it. You need to plug in.
All right. Am I doing mic? Debbie, is it on the desktop?
Yes.
Thanks.
Right. Close the presentation.
Okay.
Close the slide. And you're right over there.
All right. Hey, everyone. So I'm going to talk about exercise laryngoscopy, which is something we've added to the CPET lab recently. So actually, the first couple of these were done with Indian Phillip and Nikita Kohli from ENT with level 3 testing. And then Nikita and I did a few more. And then I asked Nikita if she felt okay with us just doing this on their own. And she was very pleased not to have to wake up an hour early before clinic to come in and do these. And so we've started doing them on our own. And interestingly, if you haven't checked your credentialing, everybody who's credentialed for bronchoscopy is credentialed for laryngoscopy here. So if you've never held a laryngoscope, you're still credentialed to do that procedure. So the objectives of this, I think whenever we talk about exercise testing, whenever I talk about exercise testing, I want to talk about who shouldn't come for exercise testing first, because occasionally we get some people who really shouldn't come. And then I'll just do a brief overview of the 2 sort of major types of exercise-induced airway disease we're looking at. Then we'll talk about continuous laryngoscopy with exercise. And then we'll just talk through the process of patient referral. And so feel free to take a picture of this. I'm not going to rattle off everything, but basically we don't want to do exercise testing on someone we're going to kill with exercise. And so one of the big things is we got a couple patients referred for CPETs that landed in our lab that were actually intended to be referred for cardiac stress tests. And if you think about a cardiac stress test, they're looking for cardiac ischemia. So they're going to stop someone when they become symptomatic. And during a CPET, we're like right there, like, come on, go, you can go harder, you can go. And so doing that with someone who's having active ischemia is probably unsafe. So, or any of these other conditions. And I think that doesn't come up that frequently, but what comes up the most frequently is we get someone there who really can't ride a bike or can't walk on a treadmill. So if you think your patient can't meaningfully ride a bike for 5 to 10 minutes or can't walk on a treadmill at increasing incline and speed, they're probably not the right patient for a CPET. We do have an arm bike we use sometimes. So if you feel like if it's someone in a wheelchair like that who you want to test, we can do the arm bike, although the normal values for that are not terribly well established. So we're going to get to laryngoscopy eventually, I promise. But and most of you in the room know this already, but just for some of the earlier trainees who may be listening, I like to talk about exercise-induced bronchoconstriction because it tends to follow a fairly typical pattern. And what it is, it's acute airway narrowing that occurs as a result of exercise. But symptoms tend to onset after 6 to 8 minutes of high-intensity exercise. And so if someone says, I'm short of breath when I climb a flight of stairs, they're often we'll get those patients referred to us as exercise-induced asthma, but that's not how that presents. So if someone tells you after a mile or two of running, they start to develop chest tightness, and then that chest tightness persists after the cessation of exercise and often gets worse and peaks usually 5 to 10 minutes after the cessation of exercise. So when we do exercise testing, we'll put someone usually on the treadmill because it's easier to get their heart rate up, at 85% predicted at least, and have them stay there for at least 6 minutes while we have them breathe dry air to try to increase the sensitivity for bronchospasm. And so that's how we do that test. And so inducible laryngeal obstruction is this sort of broad catch-all term for inappropriate narrowing, transient reversible narrowing of the larynx in response to external triggers. So it can involve narrowing of the vocal folds. That's the vocal cord dysfunction, paradoxical vocal fold motion that we're all really familiar with, but it can involve narrowing of the supraglottic structures as well. It can be triggered by all kinds of things, exercise, irritants, emotional stress, among other things, and it can often coexist with asthma. And so when we're thinking about the larynx, we should think about the laryngeal structures we're looking at. And so the things we're going to be looking at are the epiglottis, the arytenoids, as well as the aryepiglottic folds, your vestibular folds, your false vocal folds, and your true vocal folds. So these are all the things we're going to try to be visualizing during exercise. And every one of those things can narrow during exercise. We have more pictures coming out. And so when we're talking about exercise-induced laryngeal obstruction, it is just inducible laryngeal obstruction where exercise is the inducing factor. Sometimes people call it exercise vocal cord dysfunction, but that's a bit of a misnomer because it actually tends to start at the supraglottic structures more frequently than the glottic level, but it can happen at every level. And often glottic adduction will follow the supraglottic adduction. It tends to be inspiratory. So in a study of adolescent athletes with exertional dyspnea, about 7% of those people had exercise-induced laryngeal obstruction, but 40% of those people had exercise-induced bronchoconstriction. So exercise-induced bronchoconstriction is much more common, but patients can have both. So of the 4.8% actually had both exercise-induced bronchospasm and exercise-induced laryngeal obstruction. There's a female predominance. It's probably due to a smaller laryngeal diameter. I'll talk about that a little bit more later. And it tends to occur with high-level exercise. So the history of this is often like a high school athlete stepping up to the varsity level. And once those workouts get harder, that's a lot of the time when it'll come out. And so here's what you see when you're visualizing it. So here's another normal larynx. And then in B, we see supraglottic narrowing. So you can see the arytenoids are touching and the aryepiglottic folds are narrow. In C here, we see glottic narrowing. So you can see the vocal folds are adducted there. And here there's sort of partial supraglottic and glottic narrowing. And here we have retroflexion of the epiglottis. So any one of these things can happen when you're looking for exercise-induced laryngeal obstruction in any combination of them. And so why does it happen? Well, it's not totally clear why it's happening, sort of a nascent understanding, but there's something called the Venturi effect. And so when air is moving at the same flow through a narrower area, its velocity is going to increase. And when the velocity increases, the pressure drop becomes greater. And so if there's any laxity to those structures in that narrowing where the pressure drop is greater, that's when those structures can collapse inwards. And that's part of the reason why there's thought to be a female predominance, is they just have a narrower larynx. Tissue laxity, muscle weakness, or imbalance. So if there's an imbalance between the adductors and abducting muscles, that can increase your likelihood of narrowing. There's actually, unlike paradoxical vocal fold motion, there's not a clear overlap with psychiatric diagnoses in the same way. And there's a possible contribution of reflux, and it's really kind of interesting because laryngeal hypersensitivity can make this more likely to happen because there's increased likelihood of protecting the airway, but actually laryngeal hyposensitivity can also happen, possibly due to edema, exaggerating the narrowing that's already there. And so when you're thinking about, does your patient have EILO or does your patient have EIB? Because we can't really test for both at the same time. Here's what to think about it. So EILO is going to be inspiratory. It's going to peak at peak exercise, and it's going to stop pretty quickly after exercise because once they stop and slow down their breathing, that negative pressure will get less and they'll relax. Whereas EIB, it tends to be a true expiratory wheeze. It's going to be more typical asthma symptoms, so chest tightness. And it's going to often peak after exercise. So I'm doing high level exercise for a while, then I stop, I feel chest tightness, I feel shortness of breath, and it can persist for 30, 60 minutes, sometimes until someone takes a bronchodilator. So it's a different phenomenon. So when you're thinking about a patient who you want to refer, so typical things, history and physical, really trying to suss out exactly what the timing of the symptom is when it's happening. Is there any history suggestive of asthma or another diagnosis? I think spirometry with bronchodilator on everybody and considering provocative testing where appropriate. If there's another diagnosis, go ahead and treat it. And I think especially now, while I'm just starting the program, when I've just started doing it by myself, I think everybody should get resting laryngoscopy first, because I think the ENT folks are much better at doing a careful exam of all the anatomy. I'm really just looking for what's happening functionally. And then after that, if that's unrevealing, I think that's great to refer them for continuous laryngoscopy during exercise. And so what is continuous laryngoscopy during exercise? So this is our setup. So we have a mountain bike helmet that Marjorie's husband, Ernie Cullinan, was really nice to attach all these clamps to it for us. We mount the laryngoscope to the clamp. I should have taken the picture from the other side. We poke a hole in a neoprene mask, and the laryngoscope goes through the neoprene mask and is seated in the airway. And so when we design an exercise protocol, we can design a bunch of different exercise protocol, but we really want to try to replicate the exercise that triggers the problem. And so it's hard to do with a swimmer. But often we'll do the treadmill because when you're exercising, that's on running exercise is typically higher VO2 exercise than on a bike because you're supporting your whole body weight. It's also easier to get people who aren't used to cycling, walking fast or running fast than it is getting them to push bike pedals on the bike really hard. We use incremental protocols, so we'll just ramp them up until symptoms develop. And then as far as defining abnormal, 50% narrowing is proposed, is consistent with it. And so this is what it looks like. You can tell this patient's not going to exercise well because they showed up in dress clothing. That happens quite a bit, and that's always a bit of a red flag that they're not going to be the best at exercising. It's not always the case. And here is just normal resting laryngeal anatomy. So we can see the epiglottis is here out of the way. Arytenoids, aryepiglottic folds are open. True vocal folds are open. You can see right down into the trachea. And then just to show you a couple more. So on the left, again, normal anatomy at peak exercise. You can see everything is widely patent. It's opening with inhalation. And this patient is actually, we've only done a handful of tests, so we haven't had any great abnormals, or we've only had one really great abnormal test, and that's this one on the right. And so what you can see is actually during inhalation, the epiglottis is taking on this like horseshoe shape and actually sort of obstructing airflow during inhalation. And this got worse through progressive exercise. And we reviewed this with Nikita Kohli from laryngology, and she thought this was adult onset laryngomalacia that this patient was experiencing. Laryngomalacia.
Is that like an omega?
Yeah, it does look like an omega. She called it laryngomalacia, so I'm not sure, but it definitely looked like an omega epiglottis to me. And it was really interesting because it got worse with progressive exercise, but right at peak exercise, it got a little bit better, but he was definitely symptomatic during this. But thought this was a really interesting finding. And so our referral process. So I think for now, And I think this will this first step, I'm going to become more flexible with as I've done more and have more comfort with it. But I'd love for people just to get a resting laryngoscopy with ENT before they come. And then you just put in a CPET order and send me a message. And so I think sometimes when we have a new test, it becomes a shiny new thing. I don't think this is a test for dyspnea NOS. I think it's a test for dyspnea where there's some concern for upper airway disease. And especially people who give that history where it really happens at high level exercise, stops quickly, they hear inspiratory noise. Here is our CPET order. And we designed this order after we got a couple stress test referrals. So we make you certify that this is not a cardiac stress test before sending the patient. You'll fill everything out, but you'll just write exercise laryngoscopy in here. And we will be able to get metabolic data. So you'll get a CPET along with it. But what I found is probably because of the discomfort of the laryngoscope, we're not quite getting people to quite the same peak, although we're getting pretty high level exercise from them. So we can sort of get a CPET and exercise laryngoscopy. We can't get EIB testing and exercise laryngoscopy because of all the stuff that needs to be, EIB testing and exercise laryngoscopy because of all the stuff that needs to be connected. But please, for patients, happy to have them. And it doesn't take much longer than a regular CPAT, so we can get them scheduled pretty quickly. Thanks, everyone.
Any questions? You stay.
Thanks, Brian. It was great to hear about this. We see so much of the symptoms related to this. My question relates to a clinical observation that many times there is occult sleep disordered breathing, specifically sleep apnea, in these individuals who present with the exercise-induced laryngeal obstruction. I wonder if you could comment on that.
Yeah, I don't know that there's a really good literature foundation for that. And so it would make sense if there's edema in the larynx or whatever would narrow the larynx, that would be more likely to happen. But when I was looking through etiologies, I don't know that there's a really great literature to back that up. And, sometimes there's another phenomenon we see that I found one study that in patients with who are overweight and who have obstructive disease, there's another phenomenon where you'll hear this upper airway expiratory wheeze that we hear a lot. That's kind of the audible wheeze in the room that they were able to capture on laryngoscopy in one study. And I think it's probably a purse neck breathing, so to speak, it's almost adaptive, because if something in the upper airway is going to collapse during exhalation, it's volitional, just somewhat related, somewhat unrelated to that. But anyway, I don't know if there's it's like an area right for study. Yeah.
Thanks. So we have a question from Dr. Andrei Zinchuk. Well, question and a comment. Thanks, Brian. Amazing. Consider these individuals also having sleep apnea. Evaluation. Epiglottic collapse is a real site of collapse. If it occurs with exercise, much more likely to have obstructive sleep apnea.
Very neat. Cool. I will. Awesome. Thanks, everyone.
Any other questions, comments? All right. Thank you. Dr. Honeyden?
Hello. Okay, let's just make sure. It may or may not work. I have one little poll everywhere thing, but it's the bane of my existence. So if it does not work, you're just going to shout out your response. We're going to do it very low tech if it does not work. All right. So, all right, so I'm going to be talking about steroids in the ICU, hopefully enlighten a little bit when to pull the trigger and maybe when not to. I don't have really new data, but this is a culmination of the last few years of studies that have come out. All right, before we start, does anyone know who these gentlemen are? Recognize anybody? So the gentleman on the right is Philip Hench, who was the very first rheumatology fellow at the newly formed Mayo Clinic. And on the left is Edward Kendall, who's a biochemist. And this duo, in a fashion that is quite inconceivable today, took a newly purified compound, which they called compound E, turned out to be cortisone, bench to bedside, and gave it to the first RA patient in 1948. 2 years later, they got the Nobel Prize. So giant discovery. How they found it is also pretty interesting. Kendall, the chemist, was slaving away, mushing 3,000 pounds of animal and adrenal glands, and finally produced 1 singular gram of a compound, which she named compound A. Turned out not to be cortisone. He was really, really disappointed. Around this time, rumors were rampant that the Nazis were secretly importing bovine adrenal glands from Argentina via submarine to produce extracts for military use. It was long known that animals who underwent adrenalectomy would quickly succumb with even the minimal stress, based on the work of Addison, right? So it seemed obvious that there was something special being produced in the adrenal glands. And rumor had it that German pilots were being given such a drug to allow them to tolerate hypoxia and able to fly above 40,000 feet, which was unheard of. This led in 1941, the National Research Council set up 3 research priorities for government-funded research. Number 3 was the development of antimalarials, made sense for tropical warfare. Number 2 was the development of antibiotics, penicillin, good for wounds. And number 1 was finding this elusive thing, cortisone. So funded now by government money, 900 pounds a week of adrenal glands were being shipped to Kendall, who mushed it with this now newly formed additional team of chemists. And very quickly, they isolated compound E and synthesized it, which turned out to be cortisone. So that's our steroid history. We now use it so often. Cortisone and all its cousins are now are very much in part of our pulmonary and critical care armamentarium. So we're going to talk a little bit about steroid use in ARDS. First, the QR code is not working. So easiest probably would be to get your phone, type 37607, and then send the message Shoko H949 to join the poll. Maybe, if it works.
There was, the medical school has an education series. There was one of the people who's like a scholar for like tech, and she showed that go everywhere. She herself can't get it to her.
I know, it is terrible. It's like sure dumb luck if it works.
Mentimeter is much better, but the school doesn't have a license for it.
I know. So hopefully you were able to join. And maybe you can answer, I am not sure. How often do you consider using steroids for patients with moderate to severe non-COVID associated ARDS? Most of the time, some of the time, seldom, or never. I am a non-believer. It is not rigorous scientific research, but I just want to get a temperature of the room. Oh my God, it's. I figure this is an area of practice variation. All right, there's no non-believers at least in the room. So majority, some of the time. Most of the time, some of the time. Great. All right. So as you know, there are no proven pharmacologic therapies for ARDS. It has long been known that maybe steroids in ARDS is helpful. Many different regimens have been tested, all with rather inconclusive results, some even suggesting harm. But meta-analyses after meta-analyses have suggested that steroids for ARDS might help reduce time to extubation and mortality. Just at the beginning of the COVID pandemic was DEXA ARDS, which I think many of us missed because we're busy doing something else. I wonder what that was. This was a multi-centered Spanish study. Note, this was pre-COVID and pre-Cape Cod. They were interested in looking at the impact of steroids in patients with moderate to severe ARDS. Note, patients were enrolled early. Time from intubation to randomization was less than 2 days. And from ARDS diagnosis to first administration of steroids was less than 30 hours. So early. Cause of ARDS, by far and away, pneumonia, about half. About a quarter with sepsis, smattering of aspiration and trauma, with a PF ratio very much in the moderate range, a little less than 150. What do they get? 5 days of 20 dex, followed by 5 days of 10 milligrams dex. Easy to remember. But the results were quite astounding. Significant reduction in ventilator-free days and reduction in 60-day all-cause mortality. Almost, maybe, too good to be true. So you might wonder, was the benefit real? I told you the PF ratio mean was around 140. Only 1 in 5 of those patients were prone. So if there were really strict adherence to best practice, would we have seen the signal? Question mark. The proportion of patients on vasopressors were not described, although you noted that a quarter of them had sepsis, so maybe they needed steroids for other reasons. Over half of them had pneumonia. We'll talk about Cape Cod in a bit, but maybe the steroid benefit had more to do with pneumonia and steroids as opposed to ARDS and steroids. And as is true for all ARDS studies, the underlying lung pathology is never really closely elucidated, right? So maybe a proportion of these patients had other steroid responsive processes, and none of those patients were clearly characterized as hyper or hypo-inflammatory. That said, in 2024, the ATS came up with updated recommendations for the management of ARDS. And in the light green bar here, systemic corticosteroids is given a conditional recommendation in favor. They noted that steroids probably reduces 28-day mortality. They could not make a firm recommendation about steroid type, steroid dosage, or exact timing, but suggested that longer courses, meaning a little over a week, was probably better than ultra short, very high doses upfront, based on historical studies. If you're looking carefully, the other curious thing here is that that systemic corticosteroid bar spans all disease severities. So does severity matter? The ATS intentionally avoided a hard cutoff, but acknowledged lack of data in mild ARDS. That very same year, SCCM also published their own focus update, again, not explicitly limiting their recommendation to severe ARDS, but clearly noting that the majority of the positive trials were focused in moderate to severe ARDS patients only. So what do I do? You don't have to do it my way, but this is what I've come to do in recent years. First, I hedge. I look for other reasons to give steroids. Do they have shock? Do they have severe CAP? Or is there a steroid responsive process? I consider initiation in those with moderate to severe ARDS, but really only after I've done everything else that is proven to be true. Proning, optimizing ventilator management, paralysis, especially if early seems to be one of the benefits, so early in the disease course, to the extent that we can suss out those with high inflammatory burden, and obviously those that are rapidly worsening. Switching gears a little bit, we're talking about severe community-acquired pneumonia and steroids. Cape Cod, many of you have seen the data here, published in 2023. This was a French study looking at the benefit of hydrocortisone in severe CAP. What do we mean by severe? These were all patients either mechanically ventilated on high flow nasal cannula, non-rebreather, or a PSI, pneumonia severity index of greater than 130, which puts them in grade 5. That's the most severe category. Sick people. They smartly excluded those on vasopressors because they may end up with a different indication. Those with aspiration because they have a much more definable tempo of illness, early inflammation that sort of settles out most of the time. Avoided those with influenza as that might prolong viral clearance. Those in the intervention group receive hydrocortisone as a continuous infusion, either for 8 or 14 days. Continuous infusion isn't a practice done in the US, but theoretically might have some small advantages in that it avoids peaks and troughs, produces a stable plasma cortisol level, more closely mimics the physiologic stress cortisol response, and then thereby theoretically improving sort of the anti-inflammatory benefit, endothelial stabilization, and suppression of cytokine-induced lung injury. Everyone started off with 4 days upfront of hydrocortisone at 200 milligrams. So the numbers in the boxes are the total dosage for the day. At day 4, everyone was reevaluated. Are you better? Better meaning your PF ratio is now above 200, SOFA score is coming down. If you were, you started your taper to 100, then to 50. If you were not, you stayed at that 200 dose for 3 more days with a slightly more prolonged taper for a total 14-day course. Bottom line, those in the intervention group had a very clear improvement in 28-day, 90-day mortality, along with need for vasopressors as well as ventilator days. If you've been tracking this literature, just 1 year before Cape Cod was a different study, multi-centered VA study by Maduri, which actually failed to show benefit of steroids in exactly the same population, severe camp. Why the discrepancy, you might ask, and there's a few plausible explanations. One is difference in steroid dose and regimen. Cape Cod was an early and short approach. Start early within 24 hours of ARDS diagnosis, taper as early as 4 days if you were starting taper as early as 4 days if you were getting better, with a total regimen that may be as short as 8 days. And in this approach, we might actually be dealing more with immunomodulation, so tamping down that over-exuberant hyperinflammatory response early on. The VA study was a later and longer approach, starting 4 or 5 days in, prolonged taper over 20 days for all, regardless of whether you were doing better. So maybe paying the price now of the steroid side effects of immunosuppression, weakness, whatnot. The other possibility is that Cape Cod got lucky. They actually recruited a much more of an inflammatory phenotype. They were able to look at the CRPs, and they were almost universally quite elevated, like 70 CRP elevated. And the last thing that's really interesting and fascinating is sex differences. The VA, being the VA, had virtually no patients who were female. In Cape Cod, there was about 1/3 of the patients represented were women. The subgroup analysis really clearly suggested the benefit was stronger in women, and there's biologic plausibility in this, in that there's an estrogen steroid signaling intersect, in that in women, this may lead to reduction in capillary leak, improving microcirculatory flow, and limiting ARDS progression. So much more to come in terms of the sex difference story, but the signal for women was much, much stronger. All right, last 1 minute, septic shock and steroids. You all know large RCTs and meta-analysis support use of steroids in refractory shock due to sepsis. Adrenal was a study in 2018, which showed faster shock reversal, shorter ventilation, no clear mortality reduction. Dosing was 200 milligrams a day, preferentially as a continuous infusion, although divided doses were acceptable. Approaches had a slightly different flavor in that they added fluticortisone. This was the study that showed a mortality reduction at 90 days. Due to these two studies and many others, consistently, guidelines have recommended considering IV hydrocortisone for patients with septic shock that remains refractory to fluids and vasopressors. What does refractory mean? There is no specific vasopressor threshold provided in any guideline. Most clinicians considered norepi in that 0.1 to 0.2 range, or rapidly escalating vasopressors, or the need for second vasopressor as the threshold to pull the trigger on steroids. As an aside, the median norepi equivalent dose in adrenal and approaches where steroids were initiated was 0.2 for adrenal and 0.3 for approaches. Final thought, what's the deal with fluticortisone? Though classically described as the mineralocorticoid, it turns out fluticortisone has meaningful glucocorticoid activity. So maybe Florinef is acting as a glucocorticoid booster, not just in a mineralocorticoid effect to overcome glucocorticoid resistance so often seen in septic shock. It also has a pleiotropic effect in that it has a potential for immunomodulation. Mineralocorticoid receptors are expressed in a vast number of cell types: macrophages, dendritic cells, endothelial cells, vascular smooth muscle. So maybe improving immune homeostasis, and together helping to stabilize endothelial barrier and improving vasopressor responsiveness. So that's the probable biologic impact of this combination. Now, because there's really no other good large studies, there was a very recent network meta-analysis which pulled 17 randomized controlled trials. What's a network meta-analysis? It's like a meta-analysis on steroids. So it has the ability to compare multiple treatments at the same time, even if some of those treatments were never compared head-to-head in a single trial. So think of it as building a web of evidence as opposed to just pairwise comparisons. And in this network meta-analysis, they looked at 3 strategies: the combo, hydrocort and fluticortisone, hydrocortisone alone, or nothing. And the combo won, ultimately. Small but real differences in all-cause mortality. So my take, fluticortisone, cheap, very little downside, probably. And so if there's no contraindication to PO medication and they already have enteral access, I've been shifting my practice to add fluticortisone for the deteriorating patient with septic shock. I will end there and take questions if you have any.
Much. Dr. Zay, I'll get you the microphone.
I wanted to ask about specifically influenza and like what your practice is with that. I think with the first study you showed influenza was not excluded, but then Cape Cod influenza was excluded. I remember learning in fellowship that a lot of the retrospective data had shown harm in influenza with the use of steroids. So is your practice to avoid steroids in that situation with ARDS or not?
So very good question. So the question was about steroid use in patients with influenza-induced ARDS. I avoid it. So first, do no harm. So there's certain categories of patients in which I think the evidence is just not there or strong enough. So I avoid it in that mild ARDS category, even though that light green bar across all severities. And then people with potential harm, so influenza, for example, being one, I avoid it in those patients. Yeah, or Greg?
Sure, but do you know,
Do you know in the study where they looked at the subgroup with women, did they look, the whole estrogen steroid thing, did they look at age, like postmenopausal, premenopausal at all, or no?
Such a good question. So they didn't. And part of it is the pragmatic difficulty in knowing when people hit menopause, right? It's hard to discern in a chart. The woman's not going to tell you when their last period was. The probably the spouse or the partner or the family's not going to know. So many of these critical care trials, not just for steroids and ARDS, but for many others that have sort of examined the sex impact, struggle with this question of menopause status or perimenopause status.
Well, thanks, Shoko. Like always, it's very informative. And just wanted to say, I really liked your approach. Just wanted to say that there are 2 or 3 more studies that could come up with a proteomic analysis on a group of patients. It seems like the 2 things, CRP and IL-8, were the ones that showed more severe. So based on that, there is a paper in, I think, JAMA and somebody else had this, that if you get pneumonia, you think back, even if you haven't found a bug, pneumonia with high CRP probably should give a steroid. And Fludro, maybe.
Totally agree. I hope we get to a stage, whether it's for severe ARDS or pneumonia, to be able to better sort of personalize treatment in terms of phenotyping patients a little bit better in terms of where they are in that inflammation spectrum. Good.
Right. Thanks, everyone. Thank you, Dr. Hanadin.
So. Where? No? Where? Oh, there we go. Okay, so I'm going to talk to you about antifibrotics in ILD. So there's a lot to talk about with treatment in ILD. This is definitely a continuum between inflammation and fibrosis. We are not talking about the inflammation at all today. That's a whole separate talk. But generally the way we think about it is antifibrotics definitely in IPF, and then in non-IPF lung disease, sometimes immunosuppression, and then often antifibrotics will be added at another time. So we're going to kind of first start with IPF and where we came to. So IPF in general has a poor prognosis, as you know. It can be variable, but in general, we have not made a huge amount of progress and still quite a poor prognosis over time. So the first drug that was that came to be used was pirfenidone. Esbriet is a brand name, but now it's generic as well. It's an oral low molecular weight compound. It probably has multiple kinds of activity: antifibrotic, anti-inflammatory, and antioxidant. And so that's likely part of why it works. And so the data that we have about pirfenidone comes from the CAPACITY and the ASCEND trials. So there were 3 randomized controlled trials, all of which enrolled IPF patients, moderate IPF, based on lung function. And essentially what it showed was that there was an effect on decline in lung function. Essentially, the group that got the drug had less decline in lung function, although everybody's lung function did go down. Secondary endpoints were also met, and in pooled analysis of all the trials, there was a reduction in all-cause mortality, but that was a pooled analysis. Importantly, there was no effect on dystonic exertion or quality of life measures, and it was approved originally in Japan and then eventually in the United States in 2014. So we're now a little over 10 years since we've had this drug available to us. So just kind of talking about it on a practical basis, this is a TID medication. There are a couple of interactions with other drugs, particularly Cipro is something to be aware of. You need to avoid it in severe liver impairment. There's an up-titration period, and things to monitor in particular are patients' weight. It's something that, that I think gets discarded a little bit, but people can lose weight with it. And LFTs, it requires monitoring every few months, and then every month initially, and then every few months after that. The major side effects tend to be GI and skin, as well as kind of the systemic weight loss, as I mentioned. So nausea, kind of a little bit of diarrhea, so like bloating, dyspepsia, those kinds of things. The LFTs is not super common, but it does happen. And the skin rash is definitely something that we warn people about. So in terms of management strategies, from a GI standpoint, it's really important that the drug is taken with food. It can be dose reduced, and you can also consider reducing the dose at certain times of day if somebody has a very small meal and they're having a problem with that dose. Sometimes you can interrupt the dose. PPI sometimes helps with the nausea. Skin typically is a photosensitive rash, but you can actually get an allergic rash as well. It can be mild, but it actually can also be quite severe at times. In terms of avoidance strategies, you really want to counsel patients about avoiding sun exposure. And some of these are obvious, like applying sunblock and wearing clothing, but sometimes it's actually certain times of day, the midday particularly, especially if they're outdoors, but also things like in a cloudy day, they might not think about the fact that there is actually a lot of sun exposure, and even through glass when they're driving, and even through thin clothing, it can get a rash. But because you're telling them to avoid sun so much, think about making sure that they're not vitamin D deficient. If they develop a skin rash, you can dose reduce or discontinue the medication. And if it's severe, you will need a dermatologist to be involved. This happens fairly infrequently to have it be that severe that you need a dermatologist involved in the rash like this, particularly since patients are forewarned quite a bit. But if it truly is an allergic reaction, meaning it's not in sun exposed areas, and it seems to be related to the drug itself, then you would want to permanently discontinue the drug. So then I'll tell you a little bit about nintedanib. A brand name of that is Ofev. It's an oral tyrosine kinase inhibitor. It's a triple kinase inhibitor and has several different effects on VEGF, FGF, and platelet-derived growth factor as well. And seems to also have multiple kinds of effects in inflammation and fibrosis, as well as angiogenesis. And the data that we have on nintedanib is from the Impulsus trials. So 2 side-by-side trials that were phase 3 randomized trials, also in moderate IPF. And again, fairly similar kind of data in that there was some preservation of lung function based on FVC, which is the typical outcome that we're looking at in ILD trials. And then in this, one of the 2 trials showed improvement in time to first exacerbation, but not both trials. So there was some suspicion that this might be helpful in that way, but not definitive proof. And again, no impact on quality of life dyspnea. And it was actually approved at the same time in 2014. And so both drugs have been approved for use for more than 10 years. From a practical standpoint, this is a BID dose as opposed to a TID with the pirfenidone. It has more liver toxicity than the pirfenidone, and so both are contraindicated in severe liver failure, but we do have some people with mild liver failure who've received medication. There is some drug interactions, but not a huge amount, but it actually is the smokers have reduced exposure to the drug. So it's not that you can't prescribe it in a smoker, but they will have reduced exposure. It is best taken with food, and LFT monitoring is also monthly for the first few months, and then every few months after that with discontinuation or dose reduction if the LFTs rise. In terms of the major side effect, this is what patients generally worry about the most, is the GI side effects, the diarrhea. So in the Impulsus trials, there was actually a 62% rate of diarrhea. In the earlier phase trial was even higher. They had a huge number of dropouts. So in these trials, they actually introduced a protocol to treat aggressively with hydration and antidiarrheals. And even with that protocol in place, they had an 8% dropout. So it's definitely a significant side effect. From a practical standpoint, it is much better if the patient takes the dose with protein and with a pretty high protein meal. Also, periods of dose interruption and dose reduction are really important benefits. Sometimes if you just stop the medication for a couple of weeks, then they're able to restart at the same dose and you don't actually have to go down the dose. It is usually an early kind of finding, but it can happen anytime in treatment. You also have to worry about abdominal surgery. This is just another GI thing to watch out for. And people who have a history of perforation, you really have to have a very careful conversation as to whether you would use the drug at all. There's other important considerations with nintedanib. So you want to be thinking about arterial thrombotic effects. This is the platelet-derived growth factor. There's actually both thrombotic and potential bleeding effects with it. There was a low signal of arterial thrombotic events. And so Further studies have not suggested that this is high, but not zero. And so generally our practice is to avoid it in very high risk situations like a recent stent, recent stroke, recent MI, but it really is an individualized decision and has been different when this was the only option for some people. Similarly, bleeding. So in the original trials, people on full anticoagulation were not allowed to participate because of concern that there might be a bleeding effect related to this. And so we didn't really have actual data on those patients. And so since that time, people have been using it. And essentially the recommendation at this point is careful discussion with patients, depending on risk benefit. And if they have a very high risk or history of bleeding, that might be even more consideration and discussion. So with those two drugs over time, it has made a difference. It hasn't made all the difference that we want, but there has been reduced mortality and risk of exacerbation overall when you kind of do a meta-analysis of all the studies that have come out. This data includes both drugs, and it does favor antifibrotic use. There's no data head-to-head to suggest one is better than the other. And we also now know that it is also helpful in patients with more severe disease. So those patients were excluded from the trials, so we didn't have that information up front, but it does offer some benefit even in more advanced disease. So now I want to talk, this has been a big year for the ILD community because we have new data that's come out. So nerandomilast is a PDE4 inhibitor. It's also an oral compound, preferentially inhibiting the PDE4B and increasing intracellular cyclic AMP. It probably also has antifibrotic and anti-inflammatory effects. So the data in IPF comes from the Fibroneer IPF trial. And this was done after an initial phase 2 trial showed stabilization of lung function over 12 weeks with the 18 milligrams twice daily dosing. And so this led to the phase 3 trial, where what they did was they tested both 9 milligrams and 18 milligrams versus placebo, and they allowed people to be on background therapy. So there were different groups that were being compared, whether they were on background or on one of the other drugs. And in every single one of those groups, there was an effect of the drug, meaning that there was less decline in lung function. But again, everybody's lung function declined, but less so with the drug. So whether alone or whether background therapy, it did have effect in that way. One thing to note is that there is a drug interaction with pirfenidone. So the lower dose of the pirfenidone in combination with the nerandomilast was not effective, but the higher dose was. And that was part of what led to when it got approved that they approved the 18 milligram dose as the typical dose, though there is a reduced dose available. And it was just approved in October. And again, no effect on quality of life or symptoms. So going through practically, so it's a BID dose, as I mentioned, 18 milligrams and 9 milligrams twice daily. So there are some drug interactions to be aware of, ketoconazole, clarithromycin, that kind of group. You need to dose reduce, and then strong CYP3A inducers, you want to avoid those because they can decrease efficacy of the drug. It is also not indicated in severe liver disease or severe renal disease, mostly because those patients were excluded from the trial, but there's not any clear evidence of hepatotoxicity in this drug, and it actually does not require LFT monitoring, which is very nice. Monitoring weight was something that does need some attention paid. So in terms of side effects, the major thing was actually diarrhea, also with this drug, but certainly much less than with nintedanib. And so what you can see here is in the green, you see patients who were on nerandomilast, but no background therapy. And so at baseline, 8% with some diarrhea, and then on the 18 milligrams, 26%. Similar with pirfenidone, in combination with nintedanib, on the 18 milligram dose, 62% of people had diarrhea, but at baseline, even without any nerandomilast, the baseline with that group was 27%. That being said, if you look at the number of people who dropped out because of the diarrheal side effects, it was very low. So the degree of diarrhea seems to be more manageable with this drug than it was with the nintedanib. So that's the data that we have for IPF. So now I want to talk a little bit about progressive pulmonary fibrosis. And so when I say progressive pulmonary fibrosis or PPF, I'm talking about basically any form of progressive fibrosis that is not IPF. And so that's defined as some combination of a decline in lung function, worsening symptoms, worsening fibrosis radiographically, but it is not a distinct disease and develops in a range of patients with other forms of ILD. This kind of graph or this grid kind of gives you a sense for how many people get fibrosis in the various forms of ILD. There are a couple of different ways of defining progressive fibrosis. There's the inbuilt criteria and the ATS-ERS criteria. And I really can't get into them in great detail for this talk, but just to give you a sense that nobody really agrees on how to define this. So the inbuilt criteria and the ATS criteria differ. And I think the major things to think about in the ways they differ are the length of time since diagnosis. So the inbuilt is within 2 years, whereas the ATS is 1. It's what kind of decline is required, whether it's a relative decline or an absolute decline in the FVC, whether or not the diffusing capacity is included in the criteria, and then how they define the type of radiographic abnormality. That being said, no matter how you slice it, it's bad. So like if you are progressing with fibrosis, then your risk of death or lung transplant is increased, and it's important to treat. So first, we'll just review what's known. So nintedanib was studied in this. And so the inbuilt study, which is where the inbuilt criteria came from, looked at patients with progressive fibrosis. And essentially the data was very similar to what was seen in IPF. So there was a less decline in lung function with the nintedanib group as compared with placebo. And this was true whether or not they had a UIP pattern radiographically or a non-UIP pattern within this group. They had a really high number of people with rheumatoid arthritis in this group. It was also looked at in scleroderma population. And so the data was actually fairly similar as well. So less decline in lung function with nintedanib use. And people worried about the GI side effects that might happen in this group. And it actually was better tolerated than people thought it would be, but it's still, there's a fair amount of diarrhea, and particularly in patients who were on the combination of Cellcept, mycophenolate plus nintedanib, that was really high, like in the mid-70s. Pirfenidone was also studied in progressive fibrosis, but it's actually not approved in the US because the studies kind of fell apart. They were done during the pandemic. And so the RELIEF study that was looking in progressive fibrosis did not fully enroll. It probably helps based on the preliminary data that they had, but it was never a final study, so it's not approved for that. It was also looked at in rheumatoid arthritis, and similarly, it probably helps. And in fact, in the SARD-ILD, the systemic autoimmune rheumatic disease guidelines, they actually mention recommending pirfenidone for RA. Not that you could get it for your patients, but it is there as a recommendation. So then now there's nerandomilast. So there's Fibronir these were actually side-by-side trials. So that there was one IPF and one ILD for progressive fibrosis, and they were done essentially exactly the same way. And so it was a phase 3 randomized controlled trial testing the 2 doses. It allowed background therapy, but because only nintedanib is approved for this population, that was the only background therapy that was allowed. You had to be included by inbuilt criteria, had to have at least 10% fibrosis on CT. And it was similar in that it had more preservation of lung function with the drug. Interestingly, in this group, there was actually a reduction in mortality risk with both doses and approaching significant reduction in some of the other secondary outcomes, including hospitalization for respiratory cause. So it is a secondary outcome, but something important to think about, and may reflect the fact that they really captured a very progressive group of patients who have high mortality in a shorter period of time than the variability that is seen in IPF. And this was just approved within the last couple of months. So I also want to mention a study that has come out recently, which is looking at inhaled treprostinil as primary treatment for fibrotic ILD. So as you probably know, treprostinil is an analog of prostacyclin. It has effects on the pulmonary vasculature, but it actually also has antifibrotic effects. And in the INCREASE study, which is the study that led to its approval for treatment of PH-ILD, it actually was shown in post hoc analysis that the FVC improved. And so that led to the Teton studies. And so these are studies that are ongoing, or one is finished and one is ongoing in IPF, and then also the Teton PPF that is ongoing. And so the Teton 2 is the one that's actually been reported, but this is actually just from a web search of a presentation. The data has not really fully been published yet, but essentially it's not just that it seems to preserve lung function, but with ongoing decline, it actually seems potentially to stabilize lung function. And there was a difference between the groups of about 100 cc's. It'll depend on what happens. It seemed like it was starting to go down kind of towards the end, but it is potentially promising. We're waiting on the other study because these are two side-by-side trials just done in different areas of the world, and also on the progressive fibrosis. But the company has stated that they're going to seek approval for this based on these data. They were allowed to be on background therapy, and it was basically all groups. It was no therapy, nintedanib, or pirfenidone that they showed this. So where does that leave us with antifibrotics? So basically we have 3 drugs that are approved by the FDA for treatment of IPF, and we have 2 drugs that are approved for treatment of progressive fibrosis. You can use all of those as first-line agents, and that's the way they're approved. Nerandomilast can also be an add-on therapy, just bearing in mind that you cannot use that 9 milligram dose in combination with pirfenidone. There is no head-to-head data to suggest that one is better than the other. We definitely have more long-term data with the pirfenidone and nintedanib. We've been using them for much longer. But the side effect profile for nerandomilast definitely is promising. The fact that it has much less diarrhea than nintedanib and fairly similar to pirfenidone. But that being said, the other drugs, you can help with side effect profile and managing it clinically. The thing I think that's interesting is the survival data. You know, it's hard to know exactly how to interpret it. It's a secondary outcome. We do have open label trials that will be reported. So we'll see what happens in both groups of patients to see that. For now, I think it's important to have expectation management when you're counseling patients about antifibrotics, because the drugs that we have, they slow lung function decline. They do not halt it, they do not undo it, and they do not make people feel better. And so that needs to be something that we talk to patients. It's still reasonable and important to treat. And when you look at the number of patients with a clear diagnosis of IPF who are actually getting antifibrotic therapy, it's sadly really low in the United States and worldwide. So it is important, I think, to treat, and probably to treat early. From a practical standpoint, the meds are all through specialty pharmacy. There's foundation assistance because they're ridiculously expensive. Pirfenidone does come as a generic, and so that will likely count as far as what the insurance companies will do. And already the VA is using that as a reason to make that its first-line therapy for IPF. We don't know things like in autoimmune disease, what happens in combination with Cellcept or Rituxan, because that was not allowed in the trials. And so we do have a trial of SART-ILD looking to address this, and we don't know what's going to happen with treprostinil. And we're left with a lot of questions. You know, so what criteria should we use to define progressive fibrosis? Is it 1 year? Is it 2 years? Is any amount of fibrosis enough to start medications to try to slow that down? Do you have to wait until they've failed their standard therapy? And if that is the case, what is actually standard therapy? Because nobody agrees. And is it possible that you should be actually adding immunosuppression and antifibrotics at the same time in some patients? And can we actually identify some people in whom we know they're going to progress, we think they're going to progress earlier, and we should start medication earlier? And in IPF, we don't know which is the best first treatment and when you should be adding on second therapy. Should you be waiting for somebody to progress, or should you be doing it up front? And is there any kind of risk if you do switch between agents? I'll just briefly show you, we have ongoing trials here. How they'll fit into this whole thing is going to be interesting, but kind of consider that. And then just a thank you to the awesome group that I work with. So thanks, and I'll take questions.
Thank you very much. It was excellent. Any questions from the group?
Stunned you into silence.
Maybe. They're overwhelmed with the efficacy.
Good job. Yeah.
Just out of curiosity, any, so great presentation. Any kind of overlap with the folks having rash? It was pirfenidone more than others, right? And being a kind of a high responder. We've seen that in some other drug descriptions, right? And so given kind of its multimodal approach, it'd be kind of interesting if that was, if anyone had looked at that, or if that's some type of observation that can be
I'm
looked
not
at.
aware of anybody having ever looked at that, and it seems purely to be a photosensitivity kind of issue. So I'm not sure that that relates specifically to the mechanism, but I've never seen it. How many have we prescribed so far? I think we actually have, what did I hear recently, 90 on the drug? Is that, yeah, something in that range. Yeah. So far, actually, it's been very well tolerated. I mean, we're early. I mean, this just happened. It got approved in the very end of December, right over the holidays. And then we kind of quickly got up and running with our pharmacist to try to get the whole mechanism moving forward to be able to prescribe. And so we're really only starting to see the people who've been on it for a month or two now. And so anecdotally, I've heard of a couple people not tolerating, but mostly it seems like it's going well.
So a question from Norwalk PCCM. Great talk. Thank you. When would you combine antifibrotic therapy?
It's a really good question, and I have absolutely no idea. So the way I've taken this to mean is IPF we know progresses. And I personally think that if somebody is on drug and has a clear diagnosis of IPF, this shows efficacy in combination beyond that drug alone. And so I think it is reasonable in conversation with that patient to have a discussion about risks and benefits of adding that drug, particularly if it's addition to the nintedanib, because the diarrhea may end up being significant. But I think it's worth the discussion. In progressive fibrosis, I think it's much less clear as to when to add a drug, because if somebody is actually stable on the medication that they're taking, it is not clear that they will continue to progress. We don't actually have that data about what happens once you start an antifibrotic in progressive fibrosis. I don't think we have that long-term data to be able to guide us as well. But I have a low threshold. Whether to switch because of that mortality data, I really think that is very difficult to say, and I don't think that there's anything that makes it clear. If somebody is not tolerating the drug, if they're miserable on the drug they're on, I think it is definitely reasonable to try to switch.
Question from Dr. Pisani.
Danielle, what do people speculate? Why none of these trials show any benefit in dyspnea or quality of life? And obviously, I'm sure people talk about why they think that is.
Yeah, it's really hard. I mean, well, part of it is because nobody's getting better, right? I mean, like if you look at the data, everybody's getting worse. It just depends on how fast they're getting worse. And so you wouldn't expect that their symptoms are going to improve in any way. And I think it's also the amount of effect that you get from the drug in a single year of study or even half a year of study is so small that I think it would be very difficult to measure in terms of symptoms. Where I think you see the benefit of these drugs is year over year, and that's not really being studied.
Do you guys then have a sense in your patients, in your patients that you think they're getting less? I mean, I don't know how you figure that out. Like, do they feel like, how would you know that they were getting less dyspnea over time, right?
There's no way to know. And yeah, I don't think there's a way to know that. And we don't implement like a dyspnea questionnaire on every single visit where we might be able to trend something like that. But dyspnea is also affected by so many other things. And when somebody starts to have increasing dyspnea, then we start working them up for pulmonary hypertension, and we send them to pulmonary rehab because they're getting deconditioned, and we make sure they're using their oxygen. And there's so many other things that it's hard to figure out.
It's like an expensive med with maybe some side effects, and if you're not feeling better,
I think it's a conversation. Right. It's a hard sell. And so that's why having the longer term mortality data is important, because that's the sell. Because I kind of explain it to people more like, you're not going to feel this. It's more like taking a blood pressure medication so that you won't have a heart attack in the future and you won't know how many heart attacks you prevented. And so I try to sell it in that kind of way. Yeah. Yeah.
All right. Thanks, everyone. We'll see you next year.